Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education. Hey, Karen, how is it going?
Great, Anne. It's good to see you.
Yeah, good to see you too. Happy summer. Yeah, so I want to start out talking about IVF treatment. And as you probably know, we get a lot of questions from people who are breastfeeding. Maybe they're sometimes even like 4 or 5 months postpartum, and they're already talking about wanting to start another IVF cycle.
Oh, yeah, especially in my clinic because we have a significantly older population. A lot of people who have struggled with infertility for a long time are coming to us with low milk production, and then they're trying to continue making their families and worried about getting older.
That's exactly right. And sometimes I'm amazed, like we work so hard to get their production up. And then they're like, oh, by the way, I'm going to go, I want to get pregnant again.
Yeah. And they've told me I have to wean in order to do another cycle.
Exactly. So the question is, do they need to wean? So there was an article that was published earlier this year. The first author was Della Giovanna. In the Archives of Gynecology and Obstetrics. And it was sort of more like a thought article about, what would be the theoretical concerns regarding continuing to breastfeed and trying IVF.
And that's always the conversation that I have with people is like, it hasn't really been studied because it's such a high risk proposition when people only have a certain number of frozen embryos that they're just like trying to get every single advantage. And then people have this theoretical concern.
Right. And then the other thing is that a lot of lactating women who are seeking IVF might be under 24 months postpartum. And there had been this inter-pregnancy interval from like the time of delivery to the next pregnancy of 24 months, although there's been some, pushback about that may not be true for everyone. It kind of depends on whether or not they had a cesarean or something like that. But that's sort of tangential. So in the article, they talk about the physiologic effects of prolactin, that a normal physiologic prolactin level actually promotes fertility because it actually provides some beneficial effect on oocyte development. It promotes the corpus luteum formation and survival, and it also promotes embryo implantation, which I didn't know. So prolactin, when it's just hanging around and circulating, actually does something, which I never really knew. Like, I only care about prolactin when it comes to lactation or if it's high.
Well, exactly.
So there's a reason for it. However, there's also evidence that when there's hyperprolactinemia, and we know that it can cause infertility, right? But we oftentimes think of that as suppressing ovulation. And it does. So it does induce a state of hypogonadotropic hypogonadism, but it also works like within the uterus and the ovaries to cause difficulty. And because it can alter the endometrial function and it can interfere with embryo implantation.
Well, that makes sense because we think that our body is trying to, continue our birth spacing while we're lactating.
Right, exactly. Yeah. So it's like, don't get pregnant. Just let's not make this work. That makes sense. Yeah. And so the question is, okay, that's theoretic, but then, do we have any data on whether or not people who are breastfeeding actually do have trouble with IVF? So the other thing that we talked about, this question about whether people who are breastfeeding should undergo IVF is also the effect of the medication on breastfeeding. And there's been some concern that the medications might reduce milk production, which, pregnancy is going to do that anyway. So in a way, it kind of doesn't matter. So now we do have evidence, though, about the effect of breastfeeding on IVF. And this was just a very recently published study that's entitled The Effect of Breastfeeding on Treatment Outcomes in vitro fertilization, frozen embryo transfer cycles. And the first author is Alyssa Hochberg from the Department of OBGYN at McGill University in Montreal, Canada. So the authors first state that because of the concerns that we already talked about and the lack of evidence on the effect of breastfeeding and IVF treatment, fertility clinics generally tend to recommend stopping breastfeeding before starting IVF treatment. But there have been some clinics that have allowed IVF treatment if the prolactin has been normalized. And we know that some people have pretty normal prolactins, especially when they're further along in breastfeeding. And if they've been menstruating, then they'll be okay with it. So this study looked at data at a single fertility center in Canada. So this is a retrospective cohort study. The women in the study were breastfeeding and underwent frozen embryo transfer sometime between 2015 and 2023. The breastfeeding cohort was matched to a cohort of non-breastfeeding women who had similar demographics. And they excluded breastfeeding women who intended to stop breastfeeding or who were counseled to stop breastfeeding before the embryo transfer cycle because they wanted to just focus on people who were actively breastfeeding. So they employed two different frozen embryo transfer protocols. So one protocol tends to use hormone replacement therapy in order to induce a cycle, and then the other protocol uses a natural cycle, which involves monitoring for endometrial thickness and the presence of a dominant follicle. But sometimes they will give a trigger shot, which is a shot of recombinant HCG. So the treatment outcomes that they measured included pregnancy rate, which they defined as by just having a positive pregnancy test, and then the clinical pregnancy rate, which is being pregnant according to like ultrasound findings, seeing a fetal pole with a positive heartbeat and on ultrasound, and then a live birth rate was also measured. And then they also looked at peak endometrial thickness before progesterone supplementation and miscarriage rate. So they had 59 women in the study group and 59 women in the control group, and the average breastfeeding duration was about 14 months. The breastfeeding women were generally younger than the control women, and they also had a higher median parity, the breastfeeding women did. They also had a higher rate of diagnosis of unexplained fertility, a higher rate of irregular periods, and a higher rate of elevated prolactin levels. So the prolactin levels were higher than the control. Among those 59 women in the breastfeeding group, 21 breastfed for less than 12 months, actually. So they were less than 12 months postpartum when they did this. And 37 women breastfed for more than 12 months at the time of the frozen embryo transfer. So when they compared those various outcomes between the breastfeeding and the non-breastfeeding patients, they found that the main difference, which reached statistical significance, was basically just the peak endometrial thickness, which was actually greater among those who are breastfeeding than those who are not. So, but in terms of like having a positive pregnancy test, miscarriage, evidence of clinical pregnancy rates, and live births, there was no difference between these two groups.
Wow.
Yeah, it's kind of amazing. So the authors felt that the in vitro fertilization and frozen embryo transfer cycles were probably able to circumvent any possible negative effects on spontaneous conception brought on by pituitary inhibition of ovulation in cases of high prolactin. They say that having a regular cycle was not necessarily associated with the pregnancy rate or clinical pregnancy rate among those doing IVF. And that the elevated prolactin levels during breastfeeding didn't seem to affect the chances of implantation and clinical pregnancy in these frozen embryo transfer cycles. So it just seems like they can overcome perhaps, and they don't really talk about like the difference in protocols if one was more successful than the other, using hormonal intervention versus natural cycle.
Well, I'm assuming that those people weren't randomized to those, but it was more based on what their cycles were like.
Right, exactly. Yeah.
That is super fascinating. And it makes me think of two things. I think one is in the past, when people have asked me questions about this, I have highlighted studies around tandem breastfeeding and the fact that there is not an increase in pregnancy loss when people are continuing to breastfeed their child and they're trying to get pregnant and have another child. So it, makes sense to me that just breastfeeding doesn't necessarily increase the risk of pregnancy loss. And the other one, which relates to so much breastfeeding research, which is they're considering breastfeeding to be a binary state. You are or you're not. And there's no accounting for intensity of breastfeeding, which, it sort of relates to the fact that so many of these people were 12 months out or greater.
Yeah.
And their prolactin was low. Like you can reach full volume and maintain that and continue to breastfeed for years and have your prolactin be low.
Yep.
But were these people who, have a baby who's a toddler breastfeeding twice a day? Or, how does that compare to somebody who has a, 7-month-old who is breastfeeding or a 5-month-old who's breastfeeding still at night and, those sorts of things? It's an
Yeah.
interesting question to me.
Yeah. Well, there was one article, sort of a large study that looked at a whole bunch of surveys. This was published a couple of years ago on like family growth. I can't remember the author, but basically what it found is that there was a higher miscarriage rate among women who were breastfeeding during pregnancy if the baby was not, if the baby was exclusively breastfed. So in other words, which implies intensity,
Mm-hmm.
and it was able to rule out like the interval of pregnancy, but they basically found that if the baby was not taking anything other than breast milk, that there was a significantly higher risk of miscarriage.
And I wonder if those were matched to similar distance postpartum. Like you said, it ruled out the
It ruled
interval,
out the
but
interval. Yeah, it
like
did.
then
Yeah.
is it specifically looking at a 4-month-old postpartum woman who is exclusively breastfeeding versus one who's mixed feeding or isn't breastfeeding?
Yeah, it just basically looked at intensity, just whether or not the baby was getting anything else.
It's
So
so
it's based on,
interesting.
just parsing survey data. So that was because previous articles before that didn't show any evidence that breastfeeding was associated with miscarriage. And so, there's a lot of assumptions in the data for sure,
Hmm.
because it wasn't, yeah. So, but anyway, that statistically that seemed to come out, but no one seems to be very concerned about it. And it's unusual. If it's not associated with inter-pregnancy interval, then then the question is like, are they talking about, women who are breastfeeding like an 8, 9, 10-month-old who is not getting any solids yet? And also some of the years that were incorporated in that data were, early, like between 2000 and 2010. And I feel like the attitude about solids has changed. There's a little more evidence about the importance of, high iron diet and sort of moving away from food under one is just for fun, which I think had been an adage for a long time that you don't need to give your baby that much food. Like you can just breastfeed or just give formula. And I'm a big proponent of like, feed that baby, give that baby 3 squares and a couple snacks a day by the time they're 9 months. So yeah, we could probably talk about this forever, but
I
the
think we will, but that's a different podcast we have planned.
yeah, the bottom line is that I think that we should give patients who have a question about this a copy of the study and have them share it with their reproductive endocrinology folks. I would imagine this is a topic that they're well aware of because they just do this kind of stuff all the time. And so when they see research like this, they probably wonder, like, okay, maybe we can do this. We had this topic, we discussed this in our deep dive webinar. And one of the issues too to think about when someone is breastfeeding and talking about IVF, one of the considerations is how old that person is. Because if they're 45 and have one frozen embryo left, they probably aren't going to want to chance it. But if they're younger and they have a bunch of embryos, or they can go back and harvest more eggs, it's probably not as much of a loss other than the fact that it's expensive. But then someone was saying that just for the transfer that it's like $5,000 as opposed to harvesting, which is a lot more money.
Well, and there's a huge variation depending on where you are in the world and what your insurance is as to what the cost is going to be.
Yeah, it's still, I mean, I shouldn't say just, I mean, it's, super expensive. And certainly IVF is something that, we don't see people who have lower income doing. So yeah.
Yeah. Well, that is really interesting, and I think it will definitely change my practice, and that I'll be able to say that there is actually a study. And my hope is that in the future there will be more that will help us to guide our patients. I definitely agree that, you know, if you were to look at in general the populations, there's got to be a real difference in people who have a cause for their infertility who are younger versus people who their primary reason for doing IVF is that they just are older and they're thus in a rush.
Right. Right.
Well, thank you so much. And I want to tell you about a new article that I just found out about today. It was published in Obstetrics and Gynecology in July of 2025, and it's titled Association Between Breastfeeding and Long-Term Risk of Cardiovascular Disease. And it was by doctors Christine Field, Kartik Venkatesh et al. And this study showed that breastfeeding was associated with a lower estimated risk of long-term cardiovascular disease. And this was particularly true after an individual had gestational diabetes.
Mm-hmm.
We have known for some time that breastfeeding improves both maternal health and infant health, including reduced maternal cardiovascular or cardiometabolic risk factors such as prediabetes, type 2 diabetes, obesity, and hypertension, as well as reductions in several types of cancer. And recent data has highlighted a reduction in atherosclerotic cardiovascular disease, which I am going to abbreviate as ASCVD. So that risk includes that of coronary heart disease and stroke. The authors propose that the relative benefit of breastfeeding for maternal cardiovascular health may vary in the setting of a ASCVD risk-enhanced adverse pregnancy outcome, such as gestational diabetes mellitus. So if you have gestational diabetes, you are going to have a higher risk of those bad cardiovascular outcomes. Understanding the relationship between breastfeeding and that cardiovascular disease may vary by GDM status, by gestational diabetes status, is important because this high-risk population may be less likely to breastfeed and is more likely to experience adverse cardiovascular health outcomes compared to those who did not have gestational diabetes. It's like a double whammy.
Yes, absolutely.
Most cases of ASCVD, in fact, more than 80% can be prevented. And as we know, heart disease and cardiovascular disease is a huge killer of women. The future risk of developing this disease can be assessed in clinical practice with validated risk algorithms such as the Framingham Risk Score. And as a pediatrician, I don't spend as much time thinking about these things. And so it was interesting for me to read that such an approach provides an opportunity to emphasize early risk reduction and prevention in the postpartum period before the development of additional risk factors or overt disease. The American Heart gestational diabetes as a risk enhancing factor for atherosclerotic cardiovascular disease, with an emphasis on the importance of addressing the cardiometabolic risk factors after diabetes. However, both breastfeeding and clinical efforts to address cardiovascular disease in the postpartum period are suboptimal in the United States. Only 27% of individuals report exclusive breastfeeding at 6 months, and only 60% of individuals with cardiometabolic risk factors receive any counseling about their risk for cardiovascular disease. So this study was a secondary analysis of data from the prospective HAPO follow-up study, and that stood for hyperglycemic and adverse pregnancy outcome follow-up study, which was conducted. Alexa, do not disturb. This study was a secondary analysis of data. Okay, I'm going to try that one more time. This study was a secondary analysis of data from the prospective hyperglycemia and adverse pregnancy outcome follow-up study called the HAPO follow-up study, which was conducted between 2013 and 2016. And the original study had been in 2000 and 2006, which examined the relationship between pregnancy, dysglycemia, and adverse pregnancy outcomes at delivery. The follow-up study examined the relationship between the pregnancy, dysglycemia, and long-term cardiometabolic health of participants and their offspring 10 to 14 years after delivery. It was conducted across 10 sites from Barbados to Canada, Hong Kong, Israel, Thailand, the US, and the United Kingdom. And briefly, demographic and family history clinical data were collected through a standardized questionnaire and a physical exam, which included height, weight, blood pressure, was performed by trained personnel at pregnancy enrollment around 28 weeks of gestation and at the postpartum follow-up. These participants had a 2-hour oral glucose challenge, and pregnancy outcomes were determined by a records review. Then following up 10 to 14 years later, the participants had more lab work, fasting glucose, another oral glucose challenge, measures of cholesterol and triglycerides. And the authors examined breastfeeding status, which was defined as any breastfeeding compared with no breastfeeding, like we were just talking about, is so common to do. And the individuals completed questionnaires about that, what their breastfeeding exposure had been, but duration and exclusivity were not collected. So the outcomes were estimated, the outcomes were used to estimate 10 and 30-year risk of developing atherosclerotic ASCVD as assessed at the 10 to 14-year post-delivery mark, and they were modeled to include fatal and non-fatal coronary heart disease and stroke.
You have to speak louder.
Oh, okay.
Yeah.
The outcomes were estimated at 10 and 30-year risk of developing that cardiovascular disease at the 10 to 14 years after delivery point. The estimated risk was calculated using the Framingham risk score, and you can read more about this online. It is a predictive model that has been used to score individuals from age 20 to 59, and it has been validated in pregnancy among minority, racial, and ethnic groups and in international settings. And I think it's interesting in that it uses 8 risk factors to calculate the risk of atherosclerotic cardiovascular disease that include age, sex, total cholesterol, smoking status, blood pressure, whether or not hypertension was treated with medication, and diabetes. And then the authors, like I said, calculated the risk for these individuals. So, drum roll, please. The results showed us that of the 4,540 individuals in the study, just a fraction of a percent, under 80% of those reported breastfeeding. So 80% of people were breastfeeding. It didn't vary particularly by those who did or did not have gestational diabetes. And individuals who breastfed were very similar to those who did not in terms of their characteristics during pregnancy. So similar parity, similar age at gestational age at delivery, those sorts of things. At 10 to 14 years after delivery, the 10-year estimated cardiovascular risk was 2.3% for those who breastfed compared to 2.5% for those who did not breastfeed. And that doesn't sound like a very big difference. It's, 0.2%, which is considered statistically significant. And so I was reading this and I was like, okay, I'm not super impressed by that. And then I had to get deep into the statistics. We're going to go there in just a second. But at the 30-year estimate, the risk was 6.2% for those who breastfed compared to 6.9% for those who did not breastfeed. And in adjusted analyses, breastfeeding was associated with a slightly lower estimated risk of ASCVD over the subsequent 10 years. So then they start going through a whole bunch of statistics talking about adjusted beta values. And I had to do a little mini review and remind myself that in statistics, a beta coefficient is a standardized regression coefficient that represents the strength and direction of the relationship between a predictor variable and a dependent variable. And it indicates how much the dependent variable is expected to change for every one standard deviation increase in the predictor variable while holding this constant. So basically, it is a shortcut that we use that allows us to get a better idea of, we're only seeing these people 10 years after they delivered. What is their cardiovascular risk going to be in 30 years?
Right.
And when you go through all the statistics, it says the beta coefficients translate to an approximately 5% reduction in estimated cardiovascular risk with breastfeeding across the whole study population. And when we look at the difference between those who breastfed those who had gestational diabetes and those who did not, it was even a bigger difference. The beta coefficient translate to a 15% reduction in estimated cardiovascular disease risk with breastfeeding among those with gestational diabetes.
That's huge, 15% risk.
Yeah, sounds a lot more exciting than the 0.2% that I was first reading, but it really does make an impact as people get older.
Yeah. Well, and also, as you mentioned, this is any breastfeeding. If they were to look at duration of breastfeeding, which the Women's Health Study did, they were able to parse that with the cumulative months of breastfeeding. Even that, even if you're not talking about exclusive, but if you can talk about duration even, or cumulative months, that can make a big difference.
Yeah. Any breastfeeding could literally be one day. And that is a very different amount of, I love there's a TED talk of a cardiologist talking about how she used to put her pumped milk in the refrigerator and see that cream layer on top and know she was pumping cholesterol out of her body and
oh, I love that.
Improving her future health. It's a great one.
That's actually really great visual to be thinking about for people. Like when you're trying to explain that, I always tell people, when you're pregnant, you get this cardiovascular hit and you're going to reverse that with breastfeeding. But to also say, and you can see it when you pump out all that cream.
Yeah.
Yeah.
I decided to have a quick look and see if I could find that. I'll see if I can find it later and I'll attach it if I can find it. But it's like breastfeeding yourself healthy or something like that. It was a great TED talk. The authors go on in the discussion to talk about how, breastfeeding was associated with a slightly lower estimated 10-year and 30-year cardiovascular disease risk measured after delivery. And interaction analyses revealed that the protective association between breastfeeding was higher among individuals who had gestational diabetes. There's a bunch of additional secondary analysis that extends prior epidemiologic studies that have primarily examined the separate but not combined contributions of GDM and breastfeeding to
be a little louder.
So they did a lot of secondary analysis, and that extends prior epidemiologic studies that have primarily examined the separate but not combined contributions of gestational diabetes and breastfeeding to cardiovascular disease events across the lifespan. The 2018 Agency for Healthcare Research and Quality of Comparative Effectiveness Review Summarizing findings from 5 cohort studies included 440,000 individuals, found there was insufficient evidence to establish a clear association between breastfeeding and cardiovascular disease. However, a more recent systematic review of 8 observational studies concluded that any breastfeeding was associated with a 10% lower risk compared to no breastfeeding. And that one really hit the headlines. Of course, studies don't usually stratify this out among adverse pregnancy outcomes like gestational diabetes. So I think there's a lot more to this article, and just in the interest of time, I will let people who are interested go ahead and dive into it. At the end, the authors did remind us that, you know, breastfeeding among those with prior GDM is associated with a reduction. However, this is not a, it doesn't show causality. And that being said, it is a very impressive result. And I was really excited to see the study.
Yeah, yeah. I think that there's so much other evidence for that too. Like I know that there's been some evidence, a fair amount of evidence about the lower risk of non-alcoholic fatty liver disease, which is also like sort of a marker. And there's also a lower amount of visceral fat measured. I think this was done in Korea where they did this huge study looking at age and visceral fat. Visceral fat is that active, metabolically active fat that, is responsible for all the bad stuff that happens to us. And among these Korean women, they found that the longer they breastfeed, the less visceral fat. And so that's what I tell people. Like my storyline for people when they're breastfeeding, when they talk about, gosh, I don't know, maybe it's not worth like, how long should I breastfeed? Like how long does it matter, right? And I talk about this reversal process and that when people are pregnant, they accumulate this fat in their belly, around their breasts, in their arms. The fat that's in the thighs and the butt doesn't matter as much. It's not as metabolically active. And that breastfeeding helps to reverse that. And that kind of motivates people. I think the thing is that we don't have good evidence for is what about people who have low glandular tissue, who are,
That's
they're
exactly what I was thinking as you said that, because I think, when breastfeeding is going well, people ask that question in a very different way. They're like,
uh-huh.
yeah, I'm going back to work or I'm going on a trip and I'm wondering if it's worth it to continue through, this next thing that's happening in my life.
Right, exactly.
Versus the person who is literally making 2 ounces of milk a day and is saying, what is the benefit of this? How much do I need for it to benefit my baby? Is usually the
Yeah,
question they're
right,
asking. And we don't
right.
know what is the impact. And we won't until some of these studies look at intensity.
Right, right. And also the question is it the amount of milk that's being made so that they're dumping these calories, they're dumping the cholesterol into the milk, reducing their level, or is it the hormone changes? Because we know that elevated prolactin also remodels the pancreas, helps to, I think, build more islets, or risk of pancreatic cancer, evidence for that among women who breastfeed. So the question is it just having that hyperprolactinemia? We just don't know. And I feel like, I wish we had more that we could share. But the thing about the gestational diabetes is that there was some evidence that people who have gestational diabetes have a lower risk of gestational diabetes with their next pregnancy if they breastfeed.
Well, and we know that people who breastfeed who had gestational diabetes have less lifetime risk of type 2 diabetes.
Right.
So there are a lot
Exactly.
of hormonal effects. And it really, I mean, hearing you talk about the effect of prolactin on your pancreas, I just got an email in my listserv about, people who are having pancreatitis with weaning. And it's so fascinating to me, the real lack of research into prolactin. Like I have a friend here who's an adult endocrinologist, and her boss is this like prolactin world expert who doesn't know anything about breastfeeding. It's
Wow, that's
all
amazing.
about, the effects of prolactin related to infertility, which,
Yeah,
is an important topic of study. But the fact that endocrinologists don't get any training in this function of this very, important hormone that has,
right.
lifelong
Yeah.
effects. It's just boggles my mind. An adult endocrinologist recently reached out to me for like, is this 1 month postpartum prolactin a value that you would expect? And I was like, well, is it, pre-stimulation or post-stimulation? Like they didn't even know that was relevant. And there are
Right,
not norms. We haven't done the studies to look at a lot of people to see, to answer those questions. How are we supposed to guide our patients clinically when we don't have the basic research?
right. Yeah, 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 yeah. But I still think that it's the sort of the take home is that it is important for the cardiovascular health, and that I think one of the studies, like the women's health study, showed that at least 3 months of breastfeeding can help to reduce that. That's what you need to reduce that risk. Maybe it wasn't women's health. It was one study that sort of decided that 3 months of breastfeeding was associated with really markedly reducing the risk of type 2 diabetes when they're older.
Well, that's really super interesting. And I think, it also goes to the fact of like we're talking about prolactin, like we know that in the immediate postpartum period, the effect of oxytocin on blood pressure is significant. And
Mhm.
so you're having, oxytocin released regularly every day if you are continuing to have, milk release and let down. And so what are those effects? I found that TED Talk for anybody who's listening who wants to check it out. It's called How Mothers Can Nurse Themselves Healthy. And the speaker was Dr. Bimla Schwarz,
Ooh, nice. Oh,
Schwarz.
yeah, she's the author on a lot of the like some of the American Heart Association articles about breastfeeding and cardiovascular health. She's one of the major researchers in that field.
Well, and I think this really goes to our need for breastfeeding departments. I'm just starting to form, like we're doing a little project here in my health center where we've gotten together like the MFM, the women's cardiologist, the behavioral health team, and us to try to make, more of a center for uh, postpartum cardiovascular health, and breastfeeding is a part of that. So we're super excited to be involved in that team, and hopefully we'll see more and more health systems making that priority.
I love that. That's amazing. Oh my gosh. I mean, that would be a good letter to the editor to talk about that because, when we talk about reducing risk factors, I mean, yeah, it should actually, I mean, and also, I mean, this gets me going when I think about like people who say just pump and dump or, just stop breastfeeding or, like all of this unnecessary, inappropriate advice to women when what they're doing is they're basically changing the trajectory of that person's life, And so when I
It's
even
like if the doctor was like, "Oh, you're really stressed. Just go home and have a cigarette."
right, right, exactly, right. There you go. Exactly. Or even that early supplementation, like it's okay, I know you're really stressed. It's okay to get formula. Look, I was formula fed, but wait a second, what about our cardiovascular health, And so I think that we need to really reframe this. And there was a recent study that demonstrated that the majority of people in this country do not understand the maternal benefits of breastfeeding. They
Oh
understand
yeah.
the benefits, but they don't understand the maternal benefits. And I'm sure that's true for physicians as well.
Well,
So,
and I think people get really, physicians get hung up on, whether or not they are doing what's in the best interest of the patient. I mean, I had a patient yesterday who it was clear that the intensity of breastfeeding that she was attempting was not sustainable with her current support system and mental health. And she was a person who has had breast reduction surgery and, was just not going to make a full supply. And so you've got the nuance of every individual patient and you help them to make their best decision. But that is very different than just flippantly telling people that it is not important.
well,
It's so
great.
fun to talk to you about this. I
Yeah,
hope you
it's
have a
really,
great day.
yeah, you too. Yeah, take care and we'll talk to you again soon.
Okay, bye, Anne.
Bye. For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.